Welcome to this short talk about public health contact tracing. I'm Mike Crilly, and in this first part we're going to be looking at coronavirus and COVID-19. So on this first slide on the left is a representation of what the virus looks like. It's a small round virus with these prominent red spikes sticking from its surface, and it's these red spikes that the virus uses to adhere to stick to human cells and infect human cells. Now it's called coronavirus because in profile it's thought to resemble a corona or a crown, and it was first identified in Wuhan in China early this year. The virus is thought to have originated in bats before being transferred to people, and it's known to particularly affect the cells that line the airways and the bowel, the gut. It's known as an RNA, a ribonucleic acid virus, and the virus attaches itself to human cells using these red spikes and actually inserts the RNA to cause the human cells to start producing, to replicate the virus within themselves. So the human cells produce a lot of virus and then eventually burst and release multiple copies of the virus into the rest of the body. It's a highly infectious virus. It's easily spread from person to person. Particularly infects the lining of the airways and the bowel and causes symptoms related to this. But it can also survive for several hours outside of the human body. So that makes it quite a difficult virus to deal with. Not only is it easy to spread the virus from person to person, but the virus can also survive for several hours in the environment in which people are living and working. It can cause a wide range of symptoms. People can be infectious for up to 2 days, 48 hours before the first onset of their symptoms. And the symptoms can include fever, cough, fatigue, and breathlessness. The symptoms can range from being very mild, almost unnoticeable, to being very severe and requiring hospital admission and treatment. And just to add to the problem is the infection can also be asymptomatic. So in some individuals they can be infected with the virus but have no symptoms at all, but we think these people are also in danger of spreading the virus to others. So individuals can actually be unaware that they are infected but have the potential to transmit the virus to other people. This is a list of the common symptoms that were seen in China in almost 56,000 people up towards the end of February this year. So you can see listed along the left are the symptoms, and the horizontal red bars represent the proportion of people in China that exhibited these symptoms. So you can see that the three leading symptoms are fever, which affected almost 88% of people, a dry cough affecting 68%, and fatigue, a feeling of tiredness and being washed out in 38% of people. Other symptoms included production of sputum or phlegm, thick either green or brown, mucus that people cough up, shortness of breath in almost 19% of people, muscle pains and or joint pains in about 15%, sore throat in 14%, headache in around 14%, chills in just over 10% in 11%, nausea or vomiting, nasal congestion and diarrhea. So you can see that the symptoms reflect infection of the airways with a dry cough, production of sputum, shortness of breath and a sore throat. And you can also see that it also affects the bowel with a sense of nausea and vomiting and diarrhea. Unfortunately, these are quite common symptoms in the community, in the population at large, and they can be shared with people who've got just a simple common cold or the flu. It seems to be that a runny nose is rarely a symptom of infection with the coronavirus. This is the list of clinical symptoms that is currently included in the general practice, the GP guidelines for Scotland. And you can see the main symptoms in bold a fever, dry cough with or without sputum, a sore throat, fatigue, pain, presumably the pain here refers to muscular pain or joint pain, and then other symptoms that are slightly less common in the UK and Scotland, dyspnea, which is the technical term for simple breathlessness or shortness of breath, SOB. Chest pains can be a feature of infection with coronavirus. Anosmia and dysgeusia, which refer to loss or change in the sense of smell or taste. Headaches, dizziness, abdominal pain, and as we've mentioned, nausea and diarrhea. So a broad range of symptoms that coronavirus can cause, but the most prominent symptoms tend to be fever, cough, sore throat, fatigue, and muscular or joint pains. This bar chart shows the occurrence of individuals testing positive for COVID-19 by age and sex in Scotland. This is data from Public Health Scotland in the middle of May 2020. So you can see the scale up the side of this chart is the incidence rate per 100,000 population. So this is the occurrence of new cases of people testing positive for COVID. And you can see as you look across the chart, we have increasing age bands from 0 to 4 years up to 65 plus years. So you can see that as people get older in Scotland, they're more likely to test positive, and we also have a tendency for women to test positive more commonly than men. But we have to bear in mind that the testing policy has changed over time in Scotland, and so this doesn't necessarily represent the true level of COVID infection in the population. This is the infection rate that we've been able to identify among the people who we tested. So people with symptoms that are compatible with having COVID, who are then receive a test, and the test is positive and confirms that they have got COVID. So we can see that in the older age group, 65 plus, it's more commonly found on testing, but it's relatively uncommon in the 0 to 4 and the 5 to 14 year olds. So uncommon in children and more common in older age groups. So the spread of COVID, or the transmission of COVID, it's easily spread from person to person. It's spread by droplets produced by coughing, sneezing, singing, possibly by talking. It's also spread by touching your mouth or your nose or your eyes with your hands if they've been contaminated with the coronavirus. We refer to the time from exposure to the onset of symptoms, the first point at which someone is exposed to the virus, to the time when they get their symptoms, as the incubation period. And for COVID, the incubation period averages 5 days, but with quite a broad range from 1 day up to 14 days. As I've said, COVID can survive for several hours on surfaces. So as well as infecting people, as well as infecting individuals, COVID can also contaminate the environment. This is a diagram illustrating how COVID can be spread by coughing and sneezing. So the outline figure in red is someone who has COVID coronavirus disease, who's infected with it. And if they cough or sneeze, then they produce a cloud of droplets. So that somebody standing near them, particularly somebody standing within 2 meters of them, is likely to be exposed to droplets containing the virus. And there are 3 types of droplets that are produced. There are quite large droplets, there are medium-sized droplets, and there are also small droplets, or what we refer to as aerosols. Now the largest droplets, the biggest droplets, tend to have a higher viral load, a much higher number of active virus within the droplet, but because they're heavier, they tend to fall to the ground much quicker than smaller droplets. The medium droplets are able to travel a further distance, so they have a lower level of virus in them, but they're able to travel a greater distance. And the smallest droplets, the aerosols, so-called aerosols, they can spread much further, and they can also remain suspended in the air, particularly in enclosed spaces, for a longer period of time. So as well as people being exposed to the virus by somebody essentially coughing in their face or coughing near to them within 2 meters, the virus can also land on floors, for example, but also on flat surfaces. So, for example, tabletops, and these are called fomites, or surfaces that are contaminated with virus. So as well as it being spread from person to person by coughing and sneezing, it can also be spread from surfaces, tabletops, door handles, taps. So if an infected person has the virus on their hands, touches a surface, and then that surface is touched by somebody else, who then touches their face, their eyes, their nose, or their mouth, they can catch the infection. The infection will be transmitted by that route. And then we've got a second person standing further away from the infected case of COVID, and they can potentially be infected by aerosols if these linger in the atmosphere, in the airspace around people, particularly in enclosed rooms, for example. So the coughing and sneezing doesn't generally produce a lot of aerosols, but some procedures, some medical procedures in enclosed spaces particularly, can increase the risk of aerosols in the atmosphere that can lead to spread of infection. So you may have heard of the R number, or the reproduction number, in relation to COVID, sometimes referred to as the RO or the RT. So the RO number refers to infection with COVID when the virus first arrived in the UK, for example, when nobody in the population was immune. And the R number is a number of secondary cases that an index case produces. So one case of COVID, how many more cases does that one case produce? And on average, COVID appears to have an R number of between 2 to 3. So you can see the diagram on the right hand side shows an index case. Unfortunately, I couldn't find an example that included 2 to 3. This one actually has a reproduction number, an R of 4. So you can see that the index case infects 4 people, and those 4 people go on to infect 4 other people. So in the early stage of an epidemic, when the population has no immunity, a viral infection like coronavirus can spread very rapidly. As people in the population start to develop immunity, or we put in measures to control the spread and try and contain the spread of COVID, then the R number comes down. So an R number of 1 means that a case of COVID, an index case of COVID, on average only passes that infection to one other person. So if the R number is less than 1, then you're starting to restrict and starting to contain the virus and stop it spreading. So the outcome, or what's referred to as the prognosis, the outcome of infection with coronavirus or the disease COVID, for previously healthy individuals, the prognosis is good. At higher risk of having a poor outcome are individuals over the age of 70, and also individuals with pre-existing chronic diseases, particularly diabetes and diseases of the heart and the lung. Overall, 75% of people have a mild illness with infection. Around 25% of the population are more moderately unwell. And among the population, about 5% go on to develop serious illness, particularly something called SARS. SARS stands for Severe Acute Respiratory Syndrome. And the scenario is usually that someone is infected with the virus. They feel moderately unwell for about a week or so, but then become much worse. And this acute syndrome, this acute lung problem, is thought to be due to an excessive immune response in the lungs to infection with the virus. And so you may sometimes see COVID referred to as novel coronavirus SARS-CoV-2, coronavirus 2. Novel meaning it's a new virus that people haven't been exposed to before. and the fact that it's referred to as SARS-CoV-2 suggests that, as we know, there have been previous infections with outbreaks with SARS-like viruses in the past, but none as severe as with the current COVID epidemic. This bar chart shows the number of confirmed COVID-related deaths by age group in Scotland. Again, you can see the scale on the left is the number of deaths per 100,000 population. And across the bottom you can see the age groups from children up to adults aged 80 plus. So if we look at the bar, the blue bar on the far right, we can see we've got almost 440 deaths per 100,000 population so far amongst those aged 80 years or more. So this number of deaths of 440 per 100,000 equates to just over 4 deaths per 1,000 population among people aged over the age of 80. So you can see it's the oldest people at greatest risk of dying from COVID in Scotland. You can see it drops quite dramatically, but still a substantial risk in those aged between 70 to 79, and then you can see there's a further substantial reduction with actually the risk of death in children between the ages of early childhood up to the age of 19, and actually amongst younger people up to about the age of 50 or so, the risk is actually very small. This is another bar chart with the red bars representing the case fatality rates that were seen in China up until the middle of February this year. So the case fatality rate is the total number of people who've died from COVID divided by the total number of people who we suspected had COVID, were confirmed case of COVID. So they had investigations that confirmed they actually had COVID. If we look at the red bar chart at the bottom, that is people with no chronic health problems, so otherwise healthy people have no known health conditions. And we can see even among people, this was in China, in the epidemic in China, the risk of dying was 0.9%, or roughly 1 in every 100 people in China who contracted the virus actually died. But we can see it was much higher in people who had existing chronic diseases. So in China, the leading chronic condition associated with an increased risk of death was cardiovascular disease, conditions such as a weakened heart failure, and in people with these sort of problems, just over 10% of them died. You can see there's also a relatively high death rate, a fatality rate amongst people with diabetes, and also amongst people with chronic respiratory disease such as chronic bronchitis or emphysema. People with high blood pressure, hypertension were also at increased risk of death from the virus, as were patients who were known to have or previously been treated for cancer or currently being treated for cancer. So that was the pattern in China. This is a diagram taken from the current Scottish GP, the Scottish Primary Care clinical guidelines for managing COVID illness. There's quite a lot of information on this slide. Again, I've included the clinical symptoms that's in the GP guidelines, but we can see that the people who are at risk of deteriorating on the right hand side with the orange flag, the people at risk of deteriorating are people on steroid therapy, people receiving corticosteroids, commonly something like prednisolone, which is used, for example, in treating rheumatoid arthritis, which compromises the immune system, or patients on immunosuppressants, so patients receiving immunosuppressants because of, for example, a kidney transplant, or as a side effect of drugs used to treat cancer. So some anti-cancer drugs depress the immune system and make people more at risk or having a serious outcome of dying if they become infected with COVID. Again, we can see people with chronic respiratory disease, chronic bronchitis and emphysema, chronic kidney and liver disease, people with cancer, people with cardiovascular disease such as heart failure or high blood pressure, people with diabetes. Smoking is also a risk factor for having a worse outcome from COVID infection. It's not clear if smoking alone is a risk factor, because smoking is also a cause of chronic lung disease, chronic respiratory disease, and also a cause of cancers and also cardiovascular disease. Being obese is also a risk factor of having a poor outcome, as is frailty, which is sometimes seen in older people, particularly people in their 80s. So the diagram on the left, which is labelled clinical course, it shows the changes in symptoms over time in what is labelled as 2 phases, from day 0, from the first onset of the symptoms, to day 7, and then further on to beyond day 14. So amongst people with an infection in the first week, they're referring to this as the virological phase, the viral infection phase. It tends to be a mild self-limiting illness in about 75 to 80% of people. But towards the end of that period, when many people start to feel better, there are a smaller group of people who become much more unwell between 7 to 10 days. It's indicated there in blue as worsening hypoxia, occurs around day 7. So that is measuring people's oxygen saturation by putting a small clip on a fingertip. They can measure the amount of oxygen in the blood, and people who previously seemed to only be having a mild self-limiting illness can actually have a relatively sudden drop in their oxygen saturation, the ability of their lungs to get oxygen into the blood. And so amongst all the people infected with COVID, we anticipate somewhere between 20 to 30% of people require hospitalisation. And among all the people infected with COVID, about 5% of people have a very poor course, a poor clinical course of COVID, and require critical care, such as being admitted to intensive care for mechanical ventilation. So we can see that for the majority of people, the illness is mild and self-limiting, but for a proportion of the population, some individuals have a very serious illness, and this SARS, sudden acute respiratory syndrome, in this immunological phase, which is a bit misleading because people, the body has an immunological response to the virus as soon as it detects the virus, but it seems to move from effectively trying to fight off the virus up until day 7, until the immune response after day 7 in people who are deteriorating, as well as trying to fight off the infection, the immune response is now overwhelming the body, particularly in the lungs, and is actually damaging the lungs, so people can't oxygenate their blood properly. So that's the illustration of the clinical course of COVID, an indication of those who tend to be at risk of deterioration, and a summary of the main symptoms that COVID presents with.